was tasked today with just describing the physical exam and the neurologic exam, and I think that's been denied by neurologists around the country, so that it's not been identified. Dr. Trifletti is a notable exception to that, who's with us here today. On the general physical exam, I'm both a fully trained pediatrician and a fully trained neurologist. So I wanted to just briefly cover some of the things that I've noticed on the exam. On the general physical exam is very important: mental status exam, neurologic exam, and I think very importantly and significant is the observational exam of the family dynamic. So evidence of streptococcal infection. I see kids come to my office in flares all the time who have just left the pediatrician's office with no diagnosis, and I take off their clothes and they have a sandpapery rash, or Pastillas lines, or perianal strep, or peeling toes. So it's very important to do a very careful exam on these kids, because I think the strep is just not being diagnosed. Remember, it can be pharyngitis, but the other things we see are the sandpapery rash, the Pastillas lines, the red cheeks with the very clearly defined borders, the angular cheilitis, impetigo, which you'll be looking at a child that's right all over their face, vulvar redness or exudatas. You can have both vaginal as well as penile strep, perianal redness, which when it's perianal strep, it has a very clearly defined border, almost like a line. And one of the other autoimmune things that causes a peeling, it almost looks like athlete's foot, but it's a 5-year-old. And they've been told it's athlete's foot, and I said, that's definitely not athlete's foot. I've seen kids come in with peticular lesions in the throat. The tonsils are generally small. We have 2 posters that we brought today that are being presented with Dr. Harley, professor of pediatric ENT at Georgetown. And what we found in the tonsils is that the tonsils are generally 1+ in size, so they're not enlarged. Occasionally, I've seen some children with just a swollen joint in the office. And guttate psoriasis, which of course is psoriasis, which has sometimes been diagnosed with eczema when it's on the outside of the elbow instead of the inside of the elbow, and often goes away when the strep is treated. The mental status exam is a little bit different in the toddlers than it is in the adolescents. And the toddlers, they're irritable, tired. The burdened appearance is characteristic, though. It's just, and I always tell the parents, do you have a previous picture of your child on your camera, on your phone? And they'll pick it up. This was his last birthday before this happened. And you see this child who looks absolutely terrified in front of you. They are very difficult to engage. Separation anxiety from the parent, from me, from one parent, from both parents. But often they have separation anxiety just from one parent. I've often wondered, and it always seems to be the opposite sex parent, if they have sexual obsessions about their parent and then just disengage, or if it doesn't seem to be a germophobic type of thing. They are aggressive, often with baby talk, or a 10-year-old, like Sue described, with a baby blanket or a stuffed animal. The rage is really something, gotta tell you. I've had to go out and get kids out of the car. I've had to chase kids out of my building. Fortunately, I have a building that's secure, and I have security downstairs. But I've had an iritis. I've been bitten. I've been punched. I've been kicked. I've had my entire desk wiped off. I've been doing this for a while, but I mean, I have a staff of 5 people who work with me, and I'm just one person, one doctor, to keep the things kind of moving along and flowing so that nobody gets hurt. Children are very sad. Sometimes the little ones have mutism, and it's interesting with the mutism because they have the same EEG finding that you see in selective mutism. The older children tend to be, I would say, more burdened, sad, flat, anxious. They can be rageful too, don't get me wrong. But they seem to have, I think, with just development, an ability to try to keep themselves together in your office. They often have psychomotor retardation. They can be very, very perseverative, difficult to interrupt, just keep going and going and going. and they're unkempt. Often these children have not taken showers. They were, just got into that early adolescent age of taking showers, for an hour or two, and all of a sudden, no showers anymore. So, poor hygiene is a big problem with the older children. And I do, there's two things I do with the parents' cell phones, smartphones. I want to see what the children look like before, and I don't want to see any pictures of the rageful episodes with the child in the room, because I don't believe they remember them, and it completely freaks them out. And if you want to have a rageful episode in your office, you can definitely trigger it by doing that. And I often just have to tell the parents, no. But the observation of the family, I think, is very noteworthy. I've been a pediatric neurologist for quite a few years. I've diagnosed children with really, really horrible things. I mean, brain deaths, taking kids off ventilators, incurable neurologic degenerative conditions, But I've never seen parents as desperate and terrified as these parents. I mean, there is just a desperation of, they know their child's in there, and they want that child out. And if you are ignoring that, I just don't know how people can ignore that. But it is definitely something in the mental status of the parents, which is very clear and definitely different than you see with other even terrible, terrible diseases. Brain tumors, much worse. These parents are often more desperate than children with brain tumors. So on neurologic exam, we see the burdened appearance, you see the dilated pupils. You don't have to measure the pupils, you just have to have one of the parents stand next to the child. Everybody's pupils should be the same size and the same ambient light. They have low tone. My experience, these children have both a dyspraxia and a motor apraxia. So if you try to get them to do something like put your hands out and hold them to see if they have choreiform movements, they kind of get this mirror thing kind of going on, where they're just trying to figure out how to organize themselves to do that. Whereas if you stand next to them and say, just copy me, they do it in a minute, because that requires really no motor planning. So it's that's very interesting. And the dyspraxia with the handwriting, I have them bring in all of their notebooks and journals from school. So, now homework is half on the computer and half on but if you have a journal from school, that you can just go right through the pages and see what the PANDAS had. They have, despite the normal tone, the low tone, remember, tone is a resistance to passive movement. Strength is just your strength. These kids are extremely strong, almost a little bit stronger than you would expect anybody to be. They have normal reflexes, which are which differentiates them at least from Wilson's disease. I think Wilson's disease is something we think about in the differential diagnosis. Those children all have hyperreflexia. The abnormal movements I've seen in these kids are choreiform movements, chorea. I've seen tics. I've seen stereotypies. I've seen a child who I believe had catatonia, who I could not help and did not treat because he had 73 electroconvulsive therapies, and his EEG just looked terrible. And I've seen most recently a child with bulismus. But these are all movements that are coming from the basal ganglia. The movements, when they're seen by someone who doesn't believe in PANDAS, if we can stop using that term one day, it would be nice, have been characterized as psychogenic movements. Like astasia, that's a term in neurology for a psychogenic movement. With astasia, you ask the person to walk, and the person walks and is almost bending all the way to the floor, and then has managed to regroup and come up without falling over. These children could never do that. They're absolutely not psychogenic, and the exam has just been inappropriately done, or inappropriately interpreted. So the symptoms that are absent, this is deep gray matter disease. So this is the striatum, so this is memory, so they don't have myoclonus, they don't have seizures, they don't have necessarily focal neurologic signs, like weakness on one side, weakness on the other side. Acute disseminated encephalomyelitis, which has been the main diagnosis that's been a source of, how do we know these children don't have acute disseminated encephalomyelitis? Well, acute disseminated encephalomyelitis affects the white matter, and this just frankly does not. And I wanted to correct something I said at a previous conference, which was that I'm seeing many more children of African American descent with this disorder, and Indian and Asian and so forth. And the other, and we also don't know what we are, by the way. I was 100% Irish until a month ago, when my brother did his ancestry thing. So I said, don't do any more tests, or if you do them, keep them to yourself. But we don't know what we are, all, genetically. I mean, in the United States, this is a melting pot. And the other thing is that if you look at the census data, you could just do a simple Google search for this. There were 1.4 million tonsillectomies done in 1959. There were in the mid 400,000 done in the 1980s, and the mid 300,000 done in the 1990s. And what we're finding in these tonsils of the kids, which we're going to publish shortly, is, and I think it correlates with the PANDAS study data that I think it's the survey data that's coming out of your group, right, with the broad spectrum antibiotics. Dr. Murphy, I'm getting mixed up. But that the broad spectrum antibiotics work better than the penicillin and Zithromax, and that's consistent with what we're finding from a microbiology standpoint in the tonsils. These kids have MRSA, serratia, actinomyces. We looked at kids with obstructive sleep apnea, chronic strep, no PANDAS, chronic strep with PANDAS. Obstructive sleep apnea, big tonsils, just mouth bacteria. Chronic strep with PANDAS, without PANDAS, just had strep in their tonsils. Chronic strep with PANDAS, that's where they had the MRSA and actinomyces and all kinds of other very resistant bacteria, which I think is consistent with what the findings were in the study of broad spectrum antibiotics. So, is it genetic? Is it environmental? I don't know. Those are questions I just throw out there.
Dr. Susan Sweeto.
Thank you. We have an hour and a half for 6 of us, so I'm going to fly, and if I start to slow down, somebody wave me on. So I do want to take the second, though, to thank not only Diana Pullman and the PANDAS Network, but the PANDAS Physicians Network, who provided support for this meeting, and absolutely huge thanks to Angelique Ledoux and all of the New York folks who've been running around like crazy. So thank you very much. As an NIH employee, I have nothing to declare or disclose, and many of you have seen this slide before. I'm putting it back up only to remind you that we're talking about a small subset of children with obsessive-compulsive disorder and Tourette's disorder. And actually, I had been worried about going at this point in the afternoon because you should have heard all this already, and I'm actually now quite glad that I am, because you did hear it all already. And you saw in Dr. Cunningham's slides, the children who were used as controls were actually children with non-PANDAS OCD and non-PANDAS Tourette's syndrome. So in my mind, there shouldn't have ever been any controversy, but hopefully by the end of today, there will never be one again. The PANDAS cohort was found because we were looking for a medical model of obsessive-compulsive disorder, and historical reports had suggested that Sydenham, Korea would be a great model. You heard from Dr. Ben-Pazzi that there's a great deal of overlap, and we're going to get into that in a minute. But just a reminder that the first group of patients described with acute onset were actually the general group of infectious triggers that included chickenpox, influenza, and strep. We've heard from Dr. Fallon this morning about the association with Lyme disease. We don't have a speaker today talking about mycoplasma, but it's increasingly recognized as a very significant trigger of neuropsychiatric symptomatology. So if you have a child with acute onset illness, please don't look just for strep, but look for Lyme if you're in the endemic areas. If you're not, if you're in the middle of that desert of Lyme, there's no reason to run the testing, but definitely ask not just the child, but exposures to mycoplasma. And then, of course, we focused on strep because of its connection to Sydenham, Korea. The history is absolutely the key, and I know some people are frustrated that we don't have objective markers of this disease, but we actually do. The presentation of a child with PANDAS is about as much different from a healthy child as you can get, as opposed to the child who has, quote, garden variety, unquote, Tourette's or OCD, in which their symptoms come on over a period of days, weeks, and months, and they hide them for a very, very long time, whereas our children cannot hide their symptoms from the day that they begin. So acuity of onset, if it'll help you remember, use the word that Paul Grant found from the French foudroyant, which means lightning-like. A foudroyant, lightning-like onset in these children. To meet criteria for PANDAS, you actually have to have 2 acute onset episodes, both of which have been triggered by infection or exposure to strep. That was actually one of the problems, that you couldn't make a PANDAS diagnosis at the first presentation of that child. The controversy was the second problem with PANDAS. So in 2010, we met in an attempt to sort of get rid of the controversy and come to agreement on things. There was complete unanimity on the clinical presentation of this. It's an extremely abrupt onset of obsessive-compulsive disorder, plus at least 2 and typically 4 or 5 of 7 different categories. And you heard during the Q&A this morning that these children have deficits in the emotional, behavioral, cognitive, motor areas of functioning. They also have abnormalities of sleep, urinary frequency, and enuresis. And it has to be, every other possible differential diagnosis has to be considered, because the third criterion for PANS is it can't be related to another known disorder. Now that list is long. It includes everything from lupus and steroid-responsive encephalitis with thyroiditis, both of which are relatively uncommon in children, but can absolutely occur, to things that we've been talking about a great deal today, acute disseminated encephalomyelitis or autoimmune encephalitis of other types. Sydenham chorea is the one that, as you heard from Dr. Benpazi, is probably the most important to make that distinction. Sydenham chorea is a well-recognized neurologic manifestation of acute rheumatic fever, and therefore you are mandated, absolutely mandated, to provide antibiotic prophylaxis against future strep, to prevent that child from having future episodes of Sydenham chorea, but also, quite importantly, to prevent them from going on to develop rheumatic carditis. The psychiatric symptoms in Sydenham chorea, as you heard earlier today, have been described since the 1600s, when Thomas Sydenham described this illness. But in actual fact, in 1922 and 1926, Hamness and Ebaugh, in 2 separate papers, wrote up a total of 36 children with Sydenham chorea. And here are the psychiatric symptoms: emotional lability, irritability, aggression, and homicidal impulses, a personality change. A number of the children were threatening suicide and were attempting, actually, had suicidal behaviors. Hallucinations, delusions, AKA psychosis. And in fact, in the 1960s, they used to talk about rheumatic schizophrenia. Acute anorexia and decreased fluid intake was incredibly common. Over half of the subjects in these 2 case series. Obsessions and compulsions were also quite common, with about 2/3 of the children having those symptoms. Separation anxiety was equally common, and when we were seeing it in the clinic back in the 1980s, Dr. Rappaport thought it was actually because of some of the side effects of the medications. We then went back and looked, and indeed the separation anxiety started with the OCD, as we now identify in the PANS children. So you heard from Dr. Benpazi, and we are not going to fight about this, but I can tell you that here in the United States, to try and get a neurologist to diagnose a child with Sydenham chorea who only has the fine piano playing movements is not going to happen. So I'm going to just assume that you're seeing the kind of kids that we were, and that you'll be able to make that distinction. Let's see, we have to get to 12 minutes. Here's a good, now does it run? I realize I only have 2 seconds to do this presentation, so. This boy has Sydenham chorea. He has proximal drifting of his arms as well as the movements of his hands. He actually keeps his chin tucked down. That's to try and keep his head still. I don't need the volume, but we'll go ahead to patient.
Okay.
Oh, if you can turn the sound off, I don't know, that would be great, because we don't need it.
Good.
This young man I would call choreiform movements, because he has only distal, a little bit of piano playing, a little bit of movement of his fingers. If you ask him to do the finger, completely steady, he had no pronator drip on an upward hand movements. Let's compare him with number 21. What do you think this guy's diagnosis is? He's normal. It's okay. We do have normal children come to the NIMH. Granted, we pay them to come to the NIMH. And hopefully we can get to the next one quickly. You can tell already, right within the first few seconds. Rock steady, but she's a good reminder that if you see abnormal movements in a child who's only 3, 4, 5, or even 6 years old, those can be perfectly normal. They do not yet have the motor inhibition to allow them to have steady hands. They have so they'll...
Spread your hands over. Good, keep your eyes closed. Come on, you can do it.
She's too loud, but you got the idea. If I would have been able to show it, and I can't with the sound so loud, the best marker was actually the fact that we had to either have them sitting down or sitting on the bed, because if you have full-blown chorea, you are flailing about and moving in such a way that you can't stand without moving. Also, obviously, the milkmaid's grip. Now, if you are finding movements that are more proximal, more than tiny bit of choreiform movements, please consider the diagnosis of Sydenham chorea. As I said, it is a well-recognized disorder and has a quite specific treatment plan. And if you're seeing the comorbidity, it could still be Sydenham chorea, because that is a function of the overall inflammation in the brain within Sydenham chorea. Our kids in the PANDAS clinic, as well as those of Dr. Latimer at Bethesda and Miro Kovacevic in Hinsdale, as I said, had 3 or 4 of these categories of comorbid symptomatology, all of which come on at the same time. And you can imagine a child who has terrible separation anxiety and needs to be close to her mother, but at the same time that mom is contaminated or is a source of violent obsession thoughts. It's torture for the entire family. The enuresis is new onset of daytime and nighttime accidents, as well as horrific urinary frequency, 5, 10, 15 times an hour going to try to void. They go and they immediately come back, may have a difference between the internal and the external sphincter for micturition. Behavioral regression, 10, 11, 12-year-old boys suddenly talking baby talk, crawling around, needing to be tucked in at night and sleeping and playing with baby toys. This girl was actually 10 at the time she became ill, but when you looked at that first picture, it looked more like something that a 4-year-old would have drawn. Dysgraphia can be used to make this diagnosis retrospectively. Lisa Snyder, when she was with my group, went into the charts for 20 children who had had a recurrent, relapsing and remitting course of their PANDAS, and what we found was that when their handwriting deteriorated and their tics had worsened or their OCD symptoms had worsened, that they or their sibling had been diagnosed with a strep infection. There was a 1-to-1 correlation. This was very similar to what Tanya Murphy found in the Putnam County schools when she went and found out that adventitious choreiform movements, behavior problems were present during positive throat cultures. Unusual margin drift is much more rare, but it would suggest some left-sided neglect in these children and more significant neuropsychological impact. Again, these data come from Tanya, and what she found was that more than 80% of children with acute PANDAS were scoring below the first percentile in the copying of the Ray Oster's complex figure. Interestingly, this is supposed to be a test of working memory, where you have the child copy it to sort of put that memory into their motor memory, and then 5 minutes later, repeat the drawing from memory. They didn't do as badly on the memory task as they did on that visual spatial, trying to make the picture that they were drawing look like the picture that they were supposed to be seeing. Well, all of these clues and many, many more are presented in the diagnostic guidelines. I saw Dr. Chang here somewhere. I don't know if he's here or upstairs, but he led our group in writing diagnostic guidelines, medical evaluation to make the diagnosis in these kids, and I hope you'll go to JCAP 2015 and get that article. Very short discussion of the model of the idiopathogenesis. You've heard this hinted at a number of times today. I just want to talk about 2 things that I think really kind of put the nail in the coffin of controversy, if we can say it that way. And that is the fact that we now have 5 very specific lines of evidence that strep is etiologically, is truly causally related to PANDAS. You heard some gorgeous work from Dr. Benros and his colleagues in Denmark. There have been a number of epidemiologic studies showing that association with OCD and strep infections, as well as longitudinal epidemiologic studies such as the Florida study. The fact that treatment reduces the OCD and tic exacerbations, to me, we reported these as 2 negative studies because we, again, failed, like we did in the IVIG trial, to see significant differences. But we went back to individual patients in whom we were able to effectively prevent strep infections. We prevented their neuropsychiatric symptom exacerbations, taking them from an average of 2.2 strep infections per year to 0. We had absolutely none among the 22 participants in this year-long study, and we also decreased their neuropsychiatric exacerbations to less than 0.6. It was interesting, that 0.6 figure, because that's exactly the number that Roger Curlin and his colleagues had found in their supposed definitive study of PANDAS, but they interpreted those data as negative. The other piece of this is the Neuro Inflammation. You've heard that we are now considering this to be a form of autoimmune basal ganglia encephalitis. And the evidence for that has been building over the past 3 decades to the point where it is frankly irrefutable. The fact that multiple symptom domains are affected means that this is a brain-based disorder. We have positive anti-nuclear antibodies in 55% of our children. Kyle Williams and the group in Turkey have shown low IgA in some children, low IgG class 2, and other abnormalities of laboratory findings. Particularly important is when you find abnormalities in the CSF, either oligoclonal bands, pleocytosis, or actually in a very, very few children, you can see disruptions of protein. Epileptiform discharges or focal slowing are present in 17% of the children on EEG, very comparable rate to what we found in the 70-some children with Sydenham chorea that we studied, and 85% of these children have abnormalities of REM sleep where they fail to establish atony during rapid eye movement sleep and therefore continue to thresh about during REM sleep. The cross-reactive antibodies, you heard Dr. Cunningham's beautiful talk about this, and it's been a privilege to work with her for the last 15 years. Just 2 years ago, we started collaborating with Chris Pittenger and his group at Yale University. They've expanded on Dr. Cunningham's work to now document antibodies against the cholinergic interneurons, which could explain some of the complexity of symptoms that we see in PANDAS. And this is his work. And cholinergic interneurons, but not other types of interneurons, and quite specific to reactivity with acute sera versus convalescent. The transfer of these antibodies is able to produce stereotypies and behavior changes, and the final piece of this is the effectiveness of immunomodulatory therapies. You've all seen this slide before, but it's just a good reminder that placebo had no impact in the early study of children with PANDAS, despite the fact that the administration of the placebo saline solution was identical to that of the IVIG, and very importantly, 9 of those 10 children who got placebo thought that they had gotten active drug when they left the hospital. Can I take 1 extra minute? Okay. It means 1 less question, but maybe it'll answer questions before you start. Here's another example of Sydenham chorea, and this girl actually has what the neurologist called chorea mole, where in addition to the adventitious movements you'll see in her toes and her hands, she has quite a bit of truncal weakness and instability, and she had to be helped up out of the chair. Chorea mole, when it gets particularly severe, actually results in a child being bedridden and they are unable to raise their head from the pillow. This is at baseline. She was from California and came to the NIMH in Bethesda, so we spent a great deal of time trying to arrange for belts and other things to help her at home. But in actual fact, she didn't need them because she was able to ambulate normally and was able to resume all functions of activity of daily living just with plasmapheresis alone. Our PANDAS patients respond just as dramatically to plasmapheresis. As you can see in this example, here's the positron emission tomography that was mentioned earlier, done by Harry Shigani and his colleagues when he was in Michigan. What they showed was that the acutely ill children had activated microglia in the caudate and putamen, which resolved with effective treatment with IVIG. And finally, and this is not your take-home message is acute onset. But this is a very important take-home message as well, and that is the fact that it is important to make this distinction between PANDAS and non-PANDAS, or acute onset and regular OCD and Tourette's, because we tried plasmapheresis in children who did not have an acute onset of their symptoms, and it had absolutely no benefit. So what does it mean? History, physical, cultures for strep, everywhere that might be. Throat, anus, vagina, nares, tonsils. Do those cultures for other pathogens when indicated. Blood work to rule in PANDAS, which is not as common as being able to rule out other illnesses. I believe that any child you're considering invasive therapy, which may very well include IV steroids because of the fact that these children would be at risk if you gave them, need to have a lumbar puncture, a swallowing study because of the coordination of voluntary and involuntary movements. A sleep study can help you find that 80% that have abnormalities indicative of REM behavior disorder. EEG, MRI is frankly not as helpful, but we're hoping that with the work that Dr. Shigani and Dr. Joe Elia are now doing in Delaware, the PET scans will soon become available. Thank you.
I just want to say that I'm the shortest, and I am actually the least academic of all of you. And I'm humbled and flattered and a little bit nervous about talking to such sophisticated people who've published so much when all I am is an ordinary pediatrician, and I don't claim to be anything else. The reason I say this is because my work has been so consuming that nothing that I do has been published, so I have nothing to put up there. I just wanted to clarify that I am now in the faculty group practice at NYU, and I'm on their faculty, but I actually am an attending pediatrician at Maimonides Medical Center in Brooklyn. I'm still, that's my primary hospital. Okay, now, what has been asked today is my perspective as a primary pediatrician on what a pediatrician does, what a pediatrician sees, and exactly what do we do with these kids? Because it is an orphan disease. Eventually, some of them get to neurologists, some of them get to psychiatrists, some of them get to immunologists, some of them get to cognitive behavioral therapists. They end up going everywhere except to their medical doctor. And the reason is this is an orphan disease. Psychiatrists don't treat immunologic disease. Neurologists don't give antibiotics. And one by one, the symptoms get recognized, but no one really has a handle on what to do for them, except for these specialized people who have spoken today. The immunologic therapy, or no one has actually discussed antibiotic therapy, and I say that there's a lot more going on there, and the person who sees them first should think of PANDAS first. The reason I say this is they'll go right to SSRI, or they'll go right to cognitive behavioral, and they won't say to themselves, gee, you know, this kid was perfectly normal until 2 weeks ago. Maybe we ought to investigate a medical reason for this. And the only person that I think really has the handle is the mommy, because she has Google. She knows that her kid has OCD and is running some tics, and she put a few things in, and boom, up comes Diana's website, and we have an educated mother. She goes to her pediatrician, and thank God for Diana. Do you realize that none of us would be here without Dr. Sweeto and without Diana? Diana has... And now we have Angelique Duldu, who just devoted 2 entire years of her life to develop this conference. And I give everybody all the credit in the world, but I'm telling you, everybody's missing this except for the mothers. So the mother will come to the doctor saying, I think my kid has PANDAS. He's had strep, he's got OCD, he's driving me crazy, he's having rages, and the doctor will say, well, maybe, but I'm gonna send you to somebody else because I have 5 minutes to see you. And if I see you for longer than 5 minutes, I'm going to lose money. So I'm going to send you to a behavioral health person because, after all, it's a behavioral health problem. And what happens is the primary pediatrician, who really is usually the front line, it's really the first one that she'll say, something's wrong with this kid. He's not normal. And he'll say, well, it is something wrong, but you can't expect me to take care of it. And I'm not blaming the pediatrician. I think it's just the environment of pediatrics today. And I'm proud to say that I'm not a today pediatrician. I started my private practice in 1976 in a very Jewish, Orthodox Jewish neighborhood, very ethnic neighborhood. We fit right into the ethnicity. And I raised these kids, I raised their kids, and now I'm seeing their grandchildren. So the original child that I saw has grandchildren in my practice, and I'm still in the family. A real pediatrician from the old time got to know the mother, got to know the father, got to know the grandmother, got to know everybody, and knew the child as they're developing. So if I have a mother who I know and love, because pediatricians in my era actually loved their mothers, if she tells me this life has changed completely, something is really wrong here, I have to believe her. I have to say she's not making this up. I know the family situation. I know what the stresses are. She just had a baby, they just moved, but still, this isn't the same child. So when a pediatrician hears, this is not my child, or an alien has stolen my child, I've gotten that a few times. Or in a Jewish word, they say dibik, which is a possession. I have a dibik in my house. This isn't him. Somebody's in there. It's not my child. Whenever we get that kind of impression, we have to step back and say, whoa, that is very strong words. Very strong words. There's something really wrong with that child. So in my practice, I think of PANDAS first. I have tried to convince all the pediatricians in my neighborhood, and I would say 80% of them think of PANDAS first. I write articles in local magazines and try to just bring up the awareness of it. The awareness problem is major in this country, major, major awareness. The ones who know the most are the parents. And there's such a gap between the parents and the primary care people, it's pathetic. What do we see? Some of them are explosive onsets, just the way Dr. Sweeto said, in the rigid PANDAS criteria that we know and love. But I must say, as the primary doctor, it doesn't always look like that. It doesn't always come that hard. It doesn't always come that fast. It's usually, if you listen carefully, and as a pediatrician, I also have residents that I teach, and I'm telling you, in pediatrics, 99.7% of what you need to know about that child's illness is in what the mother tells you. Because there's so little you can actually discern from a physical exam, which takes 30 seconds. You have to listen. You have to sit and listen, sit and listen. And what happened to this child? He was in day camp. He was going to camp every day. He loved it. He was on the bus, and all of a sudden he's terrified. He won't leave. He won't get on the bus. He's screaming. He's holding on to me. Please, no, don't put me on the bus. I can't go. I can't go. What's the matter? You loved it yesterday. Of course, you look into bullying. You look into sex abuse. You look into any kind of over-strict counselors or teachers that are terrifying the child. But many times, the situation hasn't changed, the child has changed. And that's what we have to listen for when we're listening to this mother. As a pediatrician, if you don't listen to this story, you can't make the right diagnosis. It's not the looking at the ear that tells you. It's the way he was behaving last night. It's the way the child is interacting. So now we have a mother who is our key patient representative. So what does she say? First of all, life in our house is not the same. He could be mild. It could be that he's just having trouble going to sleep and that he's just running to the bathroom 100 times and he is more anxious than he ever was, and he's not an anxious child, and he has a fear. He has a terrible fear that somebody might vomit. By the way, of all the anxieties, phobias that we see in kids with PANDAS, I must have heard the word fear of vomiting, emetophobia. I must have heard fear of vomiting 100 times in the last 5 years. It seems to be a primary fear in children who have eventually diagnosed with PANDAS. I don't know, they saw vomit, they had vomit, they're afraid that they're gonna vomit and their mother won't be there, they're afraid somebody's gonna vomit on them, they're afraid that the kid is gonna be sick, and if the kid gets sick, he may throw up. But that's what produces that separation anxiety. There's usually a phobia or a fear underneath that separation anxiety. It isn't just, I want mommy because. And sometimes they can articulate it. Sometimes you have to sort of be the detective to find out what it is. But we have kids with just severe anxiety. We have kids with just severe rage. Just yesterday, I had a child come in who took her father's MacBook and smashed it. It just opened the door of the house and smashed it down on the sidewalk in a rage that lasted about 15 minutes, and then looked at her mother and said, I'm so sorry, I broke his computer. I didn't mean to. This is the exact thing that we were just listening about. These rages come on them like a thunderstorm, and the mother said, she's never done this before. What's going on? This is every 2 days the house is turning upside down. I can't discipline her. If I try to give in to her, she's even more crazy. I don't know what to do. This is not my child. And it's every time they say it's not my child, I say, whoa, okay, not your child, then there's somebody else in their brain. And that person in their brain is PANS. It's PANS. If I can't, here's my big problem as a pediatrician. I can do strep titers, and by the way, we have very high strep titers in kids who've never had a strep throat. We have very high strep titers in kids who've had a lot of strep throats. I don't know what to do with those titers. We have mycoplasma titers, we have Lyme. I wish I could diagnose Lyme's. I don't trust I don't trust it at all, the testing. I don't feel this is a testing diagnosis. I think it's a history diagnosis. I think it's a clinical diagnosis, and I think it deserves to be treated. Even if we're not positive what caused it, we're not positive why it happened, that's what we should be doing. In my practice, on the lowest level, I do use antibiotics. I am about to post an antibiotic and immunotherapy protocol that I use in a stepwise fashion in these children. I'm going to put it on the PANDAS Network, PANDA physicians website, so that they'll know how I do it. I do use azithromycin. I do precautions about the azithromycins. I take QTC intervals before I start the children. I follow their liver enzymes. I try to be a good girl, by the way. I've never had a problem with any of it. But I never stop it in 5 days. The azithromycin's a 5-day drug. As soon as you stop it, all the symptoms come back. If you give them the same thing, you have Augmentin or another broad spectrum, as soon as you stop it, all the symptoms come back, unless you treat it for longer. And if you treat it for longer, and I don't know how long, I wish I could say in my protocol, I only say I treat it until I'm sure the symptoms are gone, and then let them stay gone for a couple of weeks, and then I don't stop the drug right away. I taper it. Now that's meshuggah. Meshuggah means crazy. You never taper an antibiotic, but this time you do. Because you're not just using antibiotics. The ones that work are the ones that have autoimmune, anti-inflammatory properties. And that anti-inflammatory property can't be just withdrawn all of a sudden. And we can't keep them on NSAIDs forever. We can't. Steroids are controversy. I find the rebound from steroid therapy to be too severe. I don't like to use it, but I'm maybe in the minority. I do use IVIG. I even do use plasma exchange in the kids that are bad enough. But what I can tell you is, don't give it for 2 weeks and then say, okay, I treated it. Look, his OCD went away. We're done. And then you stop the drug and the OCD came back. And then they say, oh, maybe we should give him another 2 weeks. It isn't going to help. The second time around is worse. So this is my This is my little capsule of what a pediatrician deals with in PANDAS, and all I can say is I'm so glad the research is finally coming through so that there's a real reason why this has happened to these kids, but it's up to us as primary care people and as the first person that sees this child to think of it, and don't be afraid to treat it. So what if you made a mistake? You're gonna, not treating it, you can cause a lifetime of dysfunction. The worst that'll happen. But the worst that'll happen, not treating it, leaving it as a lifetime of dysfunction, and you think you've protected the child because you didn't give him something. Thank you very much.
All right. Well, quickly, I'm going to talk about my perspective on management and treatment from the psychiatric point of view. Thank you. So I hope this graphic makes sense to you. What I'm trying to say with it is there's the initial disease process, the infection, inflammation, and I'm not very good at that lead to PAN symptoms, and then PAN symptoms have fallout. And so there's intervention that needs to be made both to try to help with the initiating problem, which you've heard everything about today, but I would add specialty consultation, and I'll come back to that. You have to manage the patient and their family. We'll help them manage the trouble, in the interim while the child's getting better. And there can be residual symptoms, which need help too. I put specialty consultation here to kind of emphasize that it takes many people often to try to treat these kids. It needs psychiatrists, it needs primary care doctors to identify and treat infections. Often you'll need an immunologist, a rheumatologist. We refer many of our patients to immunology because often they have allergies, often they have sinus infections, recurrent ones that we need help managing. They may go to the ear, nose, and throat doctor if they have reasons that they would normally have to get their tonsils out and they have recurrent throat infections, sleep apnea. We end up having people go to the sleep clinic for sleep evaluations. They often go to a psychologist for help with CBT if their psychiatrist doesn't undertake that. I'll think of more, but the main thing I'm trying to say is it takes many, many people often. And as you know, there's no save time, save reimbursement for connecting people, healthcare providers. So this is a pickle, a big one. Often the parent needs to be coached to be a liaison and an information sharer. So that's why I put that in there. Safety can be a real concern. The kids can be quite impulsive and they can get rage attacks. And these are seemingly unprovoked, but something provoked them, moments where they will lose it. They will have a huge meltdown. They might, and it's uncharacteristic behavior, they might bite, they might kick, they might run down the street. It might be nighttime. They might climb up a tree. They might sit on the windowsill. And it's like a thunderstorm. It comes on bang, and it can stop also after some short time generally. And they'll say, I don't know why I did it. I'm so sorry. I don't know why I acted that way. But parents need to be know about this. We've had to coach our clinic about it because we've gotten hurt by a 4-year-old, which is kind of hard to imagine, but it's true. Kids feel badly about it. Parents are upset about it and worried. Is this the new way of life? No, but it is a part of the acute presentation often. And kids need to be kept safe. They can also have desperate thoughts of suicide or homicide, and one needs to be able to have an assessment about calling 911. And then what to say to 911 needs coaching too. they say, oh yeah, this is my child with PANS. We really need some help. It's not probably going to be helpful. No, truly, this is what I've heard again and again. I think if you describe what's happening, not the diagnosis, in most situations for parents, they will get more mileage at this current time until more people understand what we're talking about. Part of the role of the primary care doctor, anybody who contacts these people, is try to help them with psychoeducation. They are totally frightened. Even if their child gets better, they all bring up the word PTSD, that they're just waiting for the next episode. And so they need support. Often they have to leave work, well, at least one of the parents or both. The other kids are kind of like, you're going to have to take care of a lot of things yourself in the interim, because we are running around to appointments, and I haven't slept all night because the child who happens to be wetting the bed is sleeping right next to me all night, every night. I can't go to the bathroom with shutting the door or take a shower. It's very hard to deal with. It's worth starting to teach parents CBT, that's cognitive behavior therapy, dialectical behavior therapy, habit reversal training techniques before even the child is ready to accept them, because if they understand the principles, they can work on enacting them. And for example, try not to let the OCD spread to the point where everyone's taking off their clothes to get into the house, etc. So that's important education. Afterwards, it's rehab. If you had a stroke, you'd go to cognitive rehab right away. Kids need to get back as soon as is reasonable and get to school, get to OT often, physical therapy. Sorry about all those action things. I think I'm talking about that. I just wanted to talk about some projects that we have going. We have a clinic where we accept kids only with very, very acute onset PANS who live right in our neighborhood, who are referred by their pediatrician, and we turn away many, many people. So I'm not saying this for an invitation, but I do want to show you a few things that we've been working on, hoping that you'll think they're interesting. We're trying to look at things in the immunological realm and infectious disease realm. I'll show you a slide about our HLA types. We are working on fortifying this data and looking further into it before we publish it. We're looking at monocytes and what they're up to when they're activated in the face of PANS. We're looking at what happens to the T cells in the presence of group A strep endotoxins, exotoxins. And we're looking for vasculitis markers both in the blood and in our MRI scans. We've done some work on treatment responses. I'll show you a bit of it. We're all looking at both first line and later line interventions. We published a bit about kids with immune deficiencies, how they have been helped by, these are case reports, IVIG replacement, as you would for any immunodeficiency. It's much easier to get IVIG for that, and how recurrent sinus infections are really a setup for recurrent episodes. And we're looking a little more carefully into symptoms and our treatment. So this is a slide that shows we've been tracking caregiver burden. There's a specific questionnaire called the Caregiver Burden Inventory. And it's been our most consistent way to track how things are going, considering all the markers, all the psychometric measures. The caregiver burden, like whoever said, like, just ask the mother how the child is doing. That would be a really good indicator. It's as tough as it is for adults taking care of adults with Alzheimer's, which is very hard. Pardon me? Yeah, they're very tough. And the slope of this is mild, but it's upgoing to tell you that we think that people are either adjusting to the stress, or we're hoping also that we're helping their kids get better, or time is. We think we're helping, but And the red line shows that in a flare, obviously the caregiver burden is higher. This is we're not ready for publishing yet because we would like to augment it and run some more analyses. An HLA frequency study. The blue ones are people who, the pink purplish ones are people who are in the database at Stanford whose relatives are going to have transplants of some kind. So they're others, not PANS. And the PANS ones are in blue. And you can just see from looking at the peeking out points that there's some HLA types that are very enriched, very significantly enriched. This is a way big difference in kids with PANS. So we're excited to keep going and finish this up. We looked retrospectively at our charts. We have a database and a biorepository, and at every visit we collect horribly long questionnaires, and our parents are great to do them. And we comb our charts, and we looked at the kids who were treated for flares with NSAIDs, non-steroidal anti-inflammatory medications. When the flares were not treated, this is not necessarily first flare, second flare, just flares, they lasted about 12 and a half weeks. I guess, let's look at the green one. If we started NSAIDs within 30 days of the beginning of the flare, it seemed to shorten the flare significantly. That's a statistically significant difference. And if the patient was already on NSAIDs and they got a flare, it was shorter lasting. I mean, 4 weeks of heck is significant. We also have similar data on corticosteroids showing that if people had one episode of PANS or at the beginning of a flare, that their flare lasted a shorter time if they were given corticosteroids, or if they were given it the first time, it was less. So 5 or 6 weeks is a chunk of life when you're taking care of someone or being that person being ill. Looking a bit through our data for interesting to us symptoms. We found that up in the upper right that 81% of our kids complain of pain, fatigue, or exercise intolerance. And complain is not maybe the right word always, because at first they don't complain about that because they're not really complaining, and they're not thinking of that if they are. But if we ask them, and as their psychological symptoms improve, we hear more and more about the pain and fatigue. And when people ask, well, are these psychotic? We did a chart review of all our patients, and very rarely, and usually with some sort of comorbidity that may complicate communication difficult, 9% might have had thought disorders, but 37% had transient, I don't know what they call them, hallucinations / sensory disturbances, especially if you ask, have you seen anything? Oh yeah, I thought I saw a guy over there, but then he wasn't there. There was a cat tail over there sticking out of the floor, but then it wasn't there. Just transient things, or transient auditory hallucinations. So that's interesting to me, especially when with a number of autoimmune encephalitis, there's frank psychosis. That's what I wanted to say, I think.
My distinguished clinical colleagues. So I'm going to start with the two that are, and then I'm just going to move to the general ones. And nobody put any cash on here, so I'm just going to use my own intuition, and we're just going to keep going. So does that work for everybody? And sorry? I'm not going to get a 0, because 0 is when she who's outside needs to come in about 5:30, and then I have to go look for a bus, and there's all kinds of things. So first, and if I can't read anything, I'll just, like some of these I just don't understand if they're in English. So for Margot, in regards to prophylactic Nsaids, are you suggesting PANDAS children who are asymptomatic should take daily Nsaids if they have an exacerbation? And how would that affect the child's stomach? There you are.
I can't generalize.
Okay, that's
Yeah.
what I thought.
We have used prophylactic Nsaids in kids that have had lots and lots of viral infections, and in kids for whom we treated acutely with Nsaids, and then we took them off or tapered them down, and then they got worse, and then we've given them back. And yes, we asked them to eat food and drink plenty of fluid
You can take the mic up too later if you want.
with their
Sorry.
NSAIDs because it can bother their stomach. We have had one person that has had some GI bleeding from it. Also can cause kidney problems. So we check their renal function every 3 months and encourage lots of fluid intake. So just because it's from the grocery store doesn't mean it can't be seriously helpful, but also seriously problematic.
Yeah,
Please jump in if you ever want.
Sure. So in kids that we have been seeing recently who have presented to our clinic that we're seeing early in the course of their illness, we've actually had a great response of treating them just with a few weeks of Nsaids from the protocol that we've gotten from Stanford, and then withdrawing them. And it seems like the kids actually, that there is something, I don't know, the benefit extends beyond the point when we stop the medication in kids. So I feel more comfortable with that. As a psychiatrist, I was never really trained in treating with anti-inflammatories, so I've been very gun-shy about long-standing anti-inflammatories. The Stanford clinic obviously has far more experience with that. So I've kept it to a short course, typically 2 to 3 weeks. But I've seen a lot of kids who continue to do well after we stop those medications.
Great.
Can I just say one more thing?
Please.
So
It's still your question.
in our review, we did find that people who flared while they were on NSAIDs had shorter flares than the group that didn't. For what that's worth.
Okay. We actually got a fresh one for Kyle. What do you consider a, quote, low IgA level? And that's a very good question because we wonder that now that we're looking at this.
Okay, so low IgA is 2 standard deviations below the age-adjusted and gender-adjusted mean, and you can speak about this as well, at least. So it's defined by the normal population data for IgA, and it is normed to age and gender up until I think age 12 to 13, something like that. And which the ASO and DNASB are not, by the way, interestingly enough, but IgA is. And so you have low IgA if you still make some IgA, but you're 2 standard deviations below where you need to be. Then you have partial IgA deficiency. And then if you make no appreciable IgA, then you have selective IgA deficiency. And we haven't seen that many kids come through. In our medical record study, we have not seen many kids with full-on selective IgA deficiency. We've seen more low IgA, so low for the age and gender. And that probably does not, or not probably, it definitely doesn't confer the same risk for upper respiratory infections or for autoimmunity as the full selective IgA does, but still could be a useful biomarker or something that a marker of immune dysregulation in some kids.
Yeah, I mean, because we now have these serum studies with Sera, and then we have the psychosis study with like 120 cases, which we're not talking about because we don't know anything yet. And I just had to educate myself, and I go online, and it's like the range, first of all, during childhood, they go like this, the norms, and the range is like 5 to 10, I mean, what's normal, so.
Yep.
I really, okay, good. I'm not as stupid as I thought. Okay. Dr. Sweeto, can you define prophylaxis antibiotic treatment in terms of duration, and are breaks recommended?
So the regimen that we use is the one published in the Red Book for use in prophylaxis in patients with acute rheumatic fever. And as such, it is not one in which there are breaks. Even a single dose missed if you're on penicillin prophylaxis results in the child not being protected for the next 5 half-lives of that drug, which is basically if they miss their Monday morning dose because of a chaotic house like mine, they're not protected again until Thursday morning, even if they take every dose religiously. So very careful administration. It's one of the reasons probably that Augmentin azithromycin work better as prophylaxis than penicillin, but azithromycin can't be used in a lot of parts of the United States because the strep bacteria are resistant to the erythromycin. So they've had superb luck with just using erythromycin in Australia and just using plain old penicillin, IM shots of penicillin in Italy, with 80% sort of cure for their children with PANDAS in Italy. But we don't have that kind of success here. And I continue it, as Dr. Murphy said in her talk, for at least a year after the last significant symptom episode. In the children who've had to have plasmapheresis or more than one round of IVIG, I usually ask for prophylaxis through adolescence, sort of that high school time when it's not worth it to fight about it, but then I put them back on when they're going off to college, or certainly if they're going into the military and will be in boot camp. The original rheumatic fever studies were done in military recruits, so 18 to 22-year-olds are still vulnerable to this.
Anybody else? I want anybody to jump in now, because now we're in the free-for-all phase, so. Okay. And then I picked these two because they were, I've never heard these at any of these conferences before. They're quite strange. Most of these are garden variety. And if you wrote this and you want to chime in, just feel free. So this one asks, is there any correlation with anti-gliadin IgG? Gliadin, does anybody know what that is?
We haven't
No.
looked at it. You've done some work on
Celiac.
there is anti-gliadin antibody in psychosis. So gliadin antibodies are and tissue transglutaminase can be markers for celiac disease. But I've seen a few kids who have concurrent celiac and PANDAS, but I don't know that there's an association per se.
Okay.
I would echo that. I've seen it just one or two. You also see some kids with antithyroid antibodies. So a person who has one autoimmune disease is more likely to have another, but not overwhelming.
So if Jenny was here, I think she could speak to this better. So I'll try to give the spiel that she's given me on this. Is that so? There are times both in PANDAS, but then also in things like Hashimoto's encephalitis, which has been renamed to steroid responsive SREAT. I forget what it stands for, but it's kids with elevated autoimmune thyroid antibodies who also develop an encephalopathy. And the thyroid antibodies are really high in that disorder, and it looks like an autoimmune antibody, but it doesn't seem to have any bearing on the clinical course of the disorder. And so what I have at least been told, and which may be happening here, is that there is some, that the autoimmune antibodies that we see, some of them may be pathogenic, and some of them may actually just be markers of immune dysfunction that these kids are having. So it may not be an actual sort of, this antibody is driving this condition, but when we see things like a gliadin antibody, or I saw, another sort of, or an ANA or something like that, it's really a marker of general autoimmune or immune dysregulation as opposed to a specific antibody that is driving some symptoms.
Anybody? Okay. Oh, Tanya.
I was just going to
please.
add, similar to that, I just found out from a hematologist that I work with that elevated B12 levels in children not taking B12 supplements can be a sign of inflammation. And I've seen a few cases of that. And usually I would just dismiss it, it just doesn't mean anything, they're taking vitamins. But these children were actually not on any supplement and had very high B12. And yeah, so
Okay, great. And the same card, part 2, is there any study with hyperbaric chambers to heal the blood-brain barrier? I'm supposed to be the barrier expert here in non-humans, and I would say none that I know of. What about for humans?
No, there isn't, and this would absolutely not be an indication for hyperbaric oxygen, as it would not do any good, and I can't imagine trying to ask a child with the kind of anxiety disorders that our kids have to comply with lying in a very small chamber for an hour.
Okay, and this one is also quite long and interesting. Children with autism have elevated levels of IL-17A in serum, and I believe the brain. Would that result in a permeable blood-brain barrier regardless of strep being able to invade the barrier via IL-17 mediated mechanism. Is that for me? Okay, in mice? Yes, I mean, one thing, I mean, we're not talking about it yet because we don't have any real solid data, but we have the sera from Sue's study, and we're actually looking at other ways that either antibodies or something else in the sera is actually breaking the barrier down besides the T cells. And we just got some cool data. So we think we're gonna find out, and we think it is. So, but it's too preliminary now to present, but it's not gonna be just one thing. I mean, I showed you, we thought it was Th17, yay, we took them away. Th1 cells are going in there. So I think it's gonna be multiple mechanisms, if that's what whoever wrote this was asking mechanistically. The rest of the card was, given the autoimmune issues present in ASD, would you expect an increased incidence of PANDAS? You mean, is that a comorbidity, autism?
I would like Dr. Schulman to speak because she actually has experience with this on the relationship between autism
Great.
and PANDAS.
Thank you.
There are two, can you hear me? Yes. Okay, there are 2 points. One is children with autistic spectrum disorder get PANDAS sometimes. And they can get it pretty severely. Their OCD can be really difficult. Their rages can be very difficult. They're certainly not immune. And it's been our impression that among the patients that we see, that is a higher incidence than in the general population of autistic spectrum disorder. I think their brains may be more vulnerable to it. That's the first part. The second part, I'm liable to get shot down, but I gotta tell my experience. We have had, in my practice, which as I said has been going on a while, several children, I can name at least 5, who have had severe autistic regression. These are children where we have videos showing how normal they were. We have school reports, how well they participated in class, how normal they were. And we can't doubt the parents. The child may be 5, maybe 4, and all of a sudden they have an autistic child on their hands. And they're put in ABA programs, they're put in schools for autistic children. But what happened to them? Do we believe in the pixie dust theory that one day my normal child was sprinkled and became autistic? Or do we think of this as a possible mechanism? And the reason I'm bringing it up, I have had one child who was recent, who we worked up and we decided he needed tonsillectomy because his tonsils were awful and he had had repeated streps. So before I give him IVIG, I insisted on him getting a tonsillectomy. And 4 weeks after the tonsillectomy, his behavior returned to normal. So we never gave him the IVIG. We're still watching him. It's about 3 months since he had his tonsils out. I have 3 other children that we treated with IVIG for this regression. For whatever reason, how we ever came to it, I don't have time to describe. And in those 3 children, 2 of them reverted. I have beautiful letters from the parents that I can show you how they went back to being their sparkling normal themselves. So there must be somewhere in this autoimmune encephalitis picture, and it may not be strep, it may be PANS, I don't even know. I believe everything is possible. There must be something that could, not the child born with autism, that's a different story. The child who wasn't born with autism, if he suddenly becomes autistic, I think we should think about it, because I think some of these children sitting in schools today who are not functioning and their lives have literally been derailed should have been evaluated and possibly treated for this. And had they been treated, we'd have a different story. I don't know whether long-term, looking at it 10 years later is worthwhile. I don't know how permanent this is. I just know I've seen them come around.
It's interesting too.
I'm sorry.
Just
Please.
I've said
I
Both
would
of you?
echo the same thing.
In
I've
turn?
had children diagnosed with autism who have returned to a normal state, and the diagnosis was firm. One of them was made at the NIH, no, I wasn't. No, I'm just saying.
What was the
child?
comment?
The child has now graduated from college and is perfectly fine.
Oh, normal. Yeah, we can't use the word normal.
What?
What was the objection? Sorry.
No, she pointed right at me.
No, I said yes, he shouldn't have done that, I'm sorry. Anyway, but that aside, there are children who you treat and then they do become normal again. Additionally, I would like to point out that there's a school, in Marshall Road Elementary School, and I keep bringing this up, in Northern Virginia, where we have diagnosed 12 children with PANDAS, 2 children with rheumatic fever, a child with sydenham chorea, and there's one child got diagnosed with post-streptococcal glomerulonephritis. And then they had a heart attack because his kidneys were damaged. But that school happens to be a school that's a magnet program for kids with emotional disabilities. So there's 50 children with severe emotional disabilities coming in and out of art, music, and physical education. So we tried to make a lot of effort to get the state and the CDC and so forth, and all we got was, we don't have a dirty school. We don't believe they have a dirty school, but those kids in the ED program need to be cultured for strep.
So I would just,
Okay.
I asked Dr. Schulman and Dr. Latimer both to comment because it is absolutely true that a severe case of PANDAS can look very much like regressive autism. I do want to caution all of the clinicians that early onset regression in the child at the typical age that you would get regressive autism, which is somewhere between 10 and 24 months, that is unlikely to be PANDAS. It certainly deserves a medical evaluation, but we did a study of over 110 children with half of whom had regressive autism, half of whom had non-regressive autism, and we looked desperately for the equivalent of PANDAS. Did not find it even among those children who had regressive autism. But that was because their symptoms started somewhere in that end of the first year, beginning of the second year of life, just when other autistic symptoms happen. And one of the reasons, if you think about what regressive autism is it's a social withdrawal, a loss of words, an eventual loss of communications and social skills. That actually is exactly the developmental markers that are required at that age, when a child who's been able to get away with baba and juice and hold their arms up for mommy and daddy has to develop more sophisticated skills. So don't overdiagnose it. On the other hand, please do think about it, because it is something that might actually be treatable. Brian?
An older child, yeah.
Okay.
There's 2 hands up, so.
How old was he when he had his symptoms? Yes, 4.5. That used to be called childhood disintegrative disorder because they couldn't figure out what it was. That disappeared because we actually know about things like autoimmune encephalitis. So if the child is 1, probably unlikely, worth at least having it enter your brain. Child 4 or 5, desperately find out what's wrong with that child.
Okay, comment or question?
A lot of them respond to many of the same modalities that we're all speaking of. You said that, Dr. Latimer, I have so many kids in college now who are autistic, you would never know are autistic. I have many, many, many. And the thing is, the key to the regressive autism is to realize that it's neuroinflammation. In fact, that was described from Hopkins in 2005. So I think it's important to not confuse it, but to recognize that it's a similar.
Okay, great. Back up there.
Disagree, because we couldn't find neuroinflammation in those 55 kids.
Just quickly.
Talking about now. So what's happened is that we also work with neurological disease, and they've discovered these unfolded proteins that are in the endoplasmic reticulum. It's an unfolded protein response. And I think you're going to find the same things in these children. That's what we're finding, and our clinicians we have internationally as well as the United States, and they're responding quite nicely. So what's happened is a membrane
Is this a question or a comment? Because I have a whole bunch of questions.
That's fine.
Okay, sorry. Age of onset. Is there growing evidence that it can be adolescent, say over 12? And is pediatric really necessary for your criteria?
So Pediatric was chosen because of work in New York at the Rockefeller University showing that 98% of individuals are immune to the M protein, which you heard from Madeline Cunningham confers lasting immunity against group A strep. 98% by the age of 12 years. We were looking for a very narrow research group. We knew from the studies in the 1940s and 1950s that acute rheumatic fever can present in young men 18 to 24 years of age. Therefore, post-strep sequelae can happen in older adolescents and young adults. It's unlikely that a child who's in a public school system is going to get through grade school years without having been exposed to enough strep that whatever it is that's cross-reacting wouldn't have activated the system if it's going to, but it is certainly possible. And I think probably to broaden that question out and make it more generalizable, the issue of an acute onset psychiatric illness having a medical cause is something we started today with and talked about how that actually is very, very common and it should always be looked for. Infections, other immune stimulating properties. Lupus is still the most common cause of psychosis, OCD, and many of the other symptoms we've been talking about today.
Okay, moving on. What if sudden onset of one or more symptoms is a form frost? What does that mean? Form frust? Ach so, okay. Is it recognized as possible PANDAS? What is it? Define for me what a form frust is.
So a form frust is a frustrated form of the illness. We first tried to describe PANDAS as a form frust of Sydenham chorea. That did not go over very well. So we moved away from that, but it actually makes a lot of sense. If a form frust is you get this many symptoms and at that many symptoms you have the diagnosis, right? Hypertension. Your blood pressure is 130 over 90, you got hypertension. Do you have it if it's 128 over 85? Who knows? So it's a cutoff issue. And I think that one of the things somebody said earlier today, because I was glad I heard it, but I want to make sure you guys heard it, was that we've been talking about really bad PANDAS all day. And maybe Tanya, you can comment on the micro episodes that these children have earlier in life so that they have a few weeks of tics or a few weeks of even a few days of separation anxiety. And they may have several of those episodes before the big blow. It's really important to culture, to do an appropriate medical workup on those early episodes, and maybe you can prevent the big one.
Good. Tanya? Oh, she did, okay.
I could actually make
Please,
one comment
yeah.
about that. When I go over the history, I often find it, I've heard diagnosis acute urinary frequency syndrome, temporary intermittent sleep disorder, a growth curve that's like this, choppy, and goes back up and choppy, and it's just, they're just not worked up. I mean, it's not the pediatrician's fault. They don't have time. I mean, I really understand that, but when they start making stuff up, I mean, that's a little bit, that's not quite okay. But I'm going to tell you just one other story. I want really to drive this home, because some kids just have mild OCD and anxiety, and their lives are kind of sort of a little bit
Like
less
we all do.
happy
Everybody in
than
New
it would
York.
otherwise
This is
be.
everybody in New York. Mild OCD
right.
and anxiety.
But, you know, they could have had happier lives. But there's other children whose lives are at risk. And I had children with GI motility studies who have early gastric satiety, abnormal GI motility studies demonstrating that their stomachs do not empty into their intestine. I have one child, a 12-year-old, went to 4 different emergency rooms in the Washington, D.C. area, had low potassium levels, abnormal EKGs, got potassium runs IV, was sent home, eventually without knowing that he couldn't eat, and was eventually sent into a psychiatric hospital where obviously these kids have separation anxiety, and that's probably the most difficult environment for them to be in. And force-fed instead of getting a tube, you know, put in. And he finally came, he was like 55 pounds, and he was a 12-year-old. And he really looked like a Holocaust survivor. I mean, we had to put a tube through into his jejunum to save him before we could even really treat him. And there's another child in Virginia who's died from PANDAS by committing suicide. I have children who have slid off roofs, crossed multiple lanes of highway traffic. Sometimes I wake up in the morning and we have a big disclaimer now, please do not leave this on an email. My child's gonna commit suicide, like call 911. But parents are afraid to call 911. So I tell the parents to go to the police department, tell them what their child has, give them information, tell them that they don't have weapons, so they don't come in and shoot the child or the parents, and try to explain it to them ahead of time. So for some of these kids, it's life-threatening, and some kids have died.
Okay, I'm going to step in, and our colleague, Dr. Jelik here, and merhaba, I spent 2 months in Turkey, and if you ever invite me or Dritan, we'll be there like the next day. I love Turkey. I want a question for Dr. Jelik because, and if it's not going to come from the audience, it's going to come from you guys because she's the only one who hasn't spoken out. And anything about her presentation about pandas in other parts of the world, Turkey, Middle East. I mean, yes, go ahead. Do you have trouble with getting accepted that pandas is real and treating it and publishing and working on it?
Actually, some of child psychiatrists, not family physicians or pediatricians, they support us, the pandas, but we argue same child psychiatrists, but we don't estimate the, how can I say?
Sorry, I can't translate from Turkish. But.
Yeah, sorry, I can't translate.
No, your English is
we used the antibiotics, and when we used first times, the families support us. We have no any legal or ethical barrier to treat our patients. Right. Sometimes they resist to, sure. But we can treat the patients. It isn't problem for us usually, but other departments, other child psychiatrists sometimes
interesting.
Push us. Yes.
Okay. 5 years ago, I got dragged back to the lab in Irvine. I was like, nobody's doing genetics on this. And the only paper I found was a paper from your group in Turkey, and like the first ever, like the TNF alpha paper. I'm like, why is there this interest in pandas and autoimmune at your? Turkey is a huge country, 70 million people. Yeah. Like, how did that nucleate at your site rather than anywhere else in Turkey? That's just a personal.
As I said in my presentation, the epigenetics and Mediterranean area for periodic fevers and thalassemia carrier states and rare disease may be most common in our area.
I see.
And genetics, it's very cosmopolitan. Arabic, Turkish, Kurdish, and very mixed genetic background we have.
Okay, so because you're geographically in this mix.
Yes, we have advantages. Yeah. Maybe not.
Again, I could go on for an hour just telling you why you should go to Turkey, but any other comments on that? No? Okay. I just wanted to make sure you had a chance to participate in this since we hadn't got to you yet.
Thank you.
Okay, and again, I'm going to be a bit of a professor here. If I see a question that I know was answered because I've been sitting here all day, I'm not going to pick it because you just weren't paying attention. Okay. What role, and this might have been covered, but we can remind, what role, if anything, does tonsillectomy play in PANDAS treatment? I know I've heard this at some of the other meetings. yes, do it, don't do it. It depends. What's the published kind of consensus for tonsillectomy?
Well, Beth has more of the prospective kind of experience. I have a retrospective experience. We actually looked at our children enrolled in a PANDAS prospective study, and a good portion of those had had a tonsillectomy, and this was predating PANDAS, so most of those did not have PANDAS as a reason. They had it as obstructive sleep apnea and a rare frequent strep. And we saw no difference in long-term severity or strep titers. But that said, I know that there are some children that get tonsillectomies because they've got these like nasty chronic strep tonsils and they do better. My perspective is retrospective. I think Dr. Latimer has had more of a prospective.
I can tell you a little bit about how that evolved. And when I first started doing that, I was following the NIH protocol, given IVIG, and most kids got better, about 80%, and about 70 or 80%. But some kids just didn't get better at all, even with broad-spectrum antibiotics. And I said, there's an infection somewhere. And then we started to look at their tonsils. We took their tonsils out, and that's when we collaborated with Dr. Cleary at Minnesota and found all the abnormal immune markers. And that's when we started to do the microbiology studies. And so I think the history in the United States with the decline of tonsillectomy rates is interesting. I mean, if everyone's tonsils, most people who had bad tonsils got them out in their 50s and 60s, and then all of a sudden HMOs came along in their 80s and 90s, and said, no, you have to have 7 strep infections in a year with 101.5, or 5 every year for 2 years, or 3 every year for 3 years. And you have to collect everything from the minute clinic, et cetera, et cetera, et cetera. The parents have strep, the kids have strep, their friends have strep, everyone's got strep, the teachers have strep. So it used to be said that you didn't get strep as a baby or as an adult. That's definitely not true anymore.
I would say that once they do have their tonsils out, that they can still get strep. So just because their tonsil's been pulled out,
They still can.
Don't ignore the strep risk.
Reduces the incidence by 85%.
Yeah, and maybe this is a sort of a weak answer to this question, but it comes up in my clinic pretty consistently, and I actually kind of believe in this answer, where I tell families that I am not, obviously at this point, child psychiatrist, I am not doing the surgery, right? I am not the one to tell you the risks and the benefits of this procedure. I can't tell you how risky it is for your child, and I can't tell you at this point how much of a benefit it would be, or if it would be a benefit at all. And so I have kind of left it to families by saying, look, if you have an ENT who feels that your tonsils should come out, then by all means. But I, at this point, I'm very interested in what they're doing here. Yeah. But I would love to see some data on this to be able to help guide families, and it seems like it's coming soon.
And as they're passing the
Comment?
microphone to Dr. Lusk, he's an ENT.
Probably the only pediatric otolaryngologist here. We looked at this day. This is what got me really interested when I was at Boys Town. And we did tonsillectomies and adenoidectomies on kids that met the criteria. 7 per year for 1 year, 3 per year per 2 years, or 2 for 3 years. And we did about 15, 16 of them. And I was skeptical. The literature didn't support it. But if you break it down, and it's going to come out in our academy literature, about 30% were cured, 30% were markedly improved, and the other 30% we didn't have any impact. And I thought it was going to be to duration of symptoms, and we analyzed that, and that wasn't the case. I couldn't pick out ahead of time who was going to benefit and who wasn't. But all of these kids had small tonsils. We did tonsils and adenoids. I think it's important that adenoids are done as well, because there are crypts within the adenoids that can harbor strep.
I'm glad you mentioned adenoids, because the experiment that Dr. Aglio and Cutforth and Cleary did in the mice, the nasal-associated lymphoid tissue is sort of the mouse equivalent of an adenoid.
That's what we used to say, tonsil, but I think adenoid is better. Yeah. I mean, given what I know more about mouse anatomy, but yeah, it's at least structurally, it's more adenoidal than tonsil. Okay, I found a Dr. Latimer question. Please clarify your statement about PANDAS kids with mutism having the same EEG changes as in selective mutism.
Oh.
What are those changes?
There's a disorder called selective mutism. It's usually seen in toddlers and children before the age of 5 or 6, where they just go to preschool and won't say anything. And they come home, and as they're falling asleep at night, they'll start talking a little bit. And on their EEGs, they have these little tiny sharp waves. And that's the same, the EEG finding that Dr. Ashura Buckley found when she reviewed the EEGs at the NIH in the PANDAS population. Very shy children.
Shy. Does that answer the question of whoever wrote that? Yeah. Okay. This is a general thing, but again, we're I think 10 more minutes of this. What? Okay. Quarter hour. I'm just giving everybody in the audience who need. Yeah, it's 5:05. That's why I said 10 more minutes. Yeah. Right. Okay. So heading to the take-home message. I have many kids who present with post-infectional new acute onset of tics or stuttering and nothing else. Is this post-infectious autoimmune basal ganglion encephalitis? And am I justified in treating them with steroids plus or minus antibiotics?
So it very well might be, and that would actually be those sort of micro episodes or non-impairing episodes that we talked about. The general rule, I'm sitting next to a neurologist so she can correct me, but the general rule is you don't treat tics just because they're bothering the parents. If it's not bothering the child, they don't need to be treated. So if you wouldn't treat them with a medication, you're certainly not going to treat them with another medication like non-steroidal anti-inflammatories, steroids, or the rest. If it's only a tic that causes no impairment, it causes no distress, it does not require treatment. Just lots of support to the parents and sort of the heads up that, hey, this was one in which there was only a minor motor symptom that's not causing your child any problems. But you know what? If he starts to exhibit anxiety, starts to have trouble eating, repeating things, get in here right away and we'll check it out.
Great.
Yeah. That said, I've had a few patients that presented to the emergency room with severe, sudden, like head-snapping tics or jerking tics, not just a little bit of, nose wrinkling, eye blinking that a lot of children with tics will have, but, significant tics that brought the family to the emergency room. The emergency room doctor, bless their hearts, was smart enough to do a rapid strep, and they had strep positive, treated with antibiotics, and by the time I got them in my clinic, they were much better. So there are some cases that are just pure tics that I think are worth exploring a little bit further, but the general kind of like mild intensity type tics that are occurring a little bit here and there, yeah, I agree that I wouldn't do a lot to
Okay.
But I think that question gets to a hesitancy that we all have, or that there's a sort of where. So we know that these are common disorders in the population, and so if they happen in a child, how far are we going to go for all of them for looking for an immune reason for their symptoms? Are we going to do a spinal tap for every kid who has OCD? Probably not, right? But if their OCD is sudden and severe and looks encephalitic, then I think that is warranted. But there are aspects of this disorder, I think, that we still need to ferret out as far as, doing the things that are probably not invasive and not harmful. I don't think that there's much of a harm in trying anti-inflammatories in kids who have an onset of OCD or tics. But that shouldn't make a encephalitic, that should not improve an autoimmune antibody disorder, right? And the kids that we see with PANDAS still, thankfully, some of them, most of them, look different than kids with autoimmune with anti-NMDA receptor encephalitis, right? And so I think that as we go along, and maybe it's that we'll grade it by severity as far as sort of how the difference for what initiation and what workup that will eventually settle on. But we need sort of more of the biomarkers and the differentiation of the presentation of kids, I think, before we make that completely.
And so that just reminds me that I don't think any of us showed the reference for the treatment guidelines. Hopefully you all know about them. The January-February issue of the Journal of Child and Adolescent Psychopharmacology had 4 articles, a treatment overview that was written by Jenny Frankovic from Stanford, Tanya and I, use of antibiotics for PANS pandas, use of immune therapies for PANS pandas, and then use of psychiatric medications and standard psychotherapeutic interventions. And we really do, I talked this morning about earlier this afternoon, about the 3 legs of the stool. Susan Schulman and I were talking about it at lunch, and she wanted to remind us, but we didn't get it done, so I'll remind you on her behalf that while all 3 legs are essential to be considered, they're probably not all appropriate at the same time. And both Dr. Murphy and Dr. Tienemann talked about the fact that during the acute crisis, you can't treat with CBT, and psychiatric medications may actually activate the child and make things worse. But you certainly could start antibiotics and a non-steroidal anti-inflammatory and get the family into the system so that by the time the child is ready, they can get an appointment, because at least in DC, there's a 5 to 6 month wait to get into that child psychiatrist.
Angelique wants me to remind all of you that the link to those JACAP guidelines is in your handout. Which exact page? On the back of the agenda, with a bunch of other useful info. Did you have a question or a comment? Sorry? Okay, we're still doing questions. I'll get to you before we break, okay? Because I thought this was interesting. I talked with many healthcare directors at colleges, such as Columbia, whose students come in with PANS diagnoses and who are still vulnerable to flares. Please address follow-up care for young adults and adults. Some directors have been told flatly that PANS does not exist in non-pediatrics. I think that's a very interesting question.
So call it ANS. I don't.
Sorry?
I said call it ANS.
Call it ANS. Sure. ANDAS, ANS. Okay.
This was like the argument between PANS and CANS, and that didn't go well. So whatever you want to call it, I don't care. Just get them treatment.
Okay.
I think if somebody's asking for accommodations on that behalf, you need to make sure why the accommodation is necessary. If they're still vulnerable to strep, so they can't be in a quad with 3 other slobby boys. No, sorry, girls could be also slobs.
You want?
Then that may well be reasonable. On the other hand, if the reason that they want the single room is so they can ritualize 8 hours a day, because what they now have is just OCD that's relatively untreated, that is not doing them a favor. So again, leave the name off, just talk about what the symptom profile is and what the impairments are.
Or post-infectious basal ganglion encephalitis.
There's no proof that
go.
that's a chronic illness, so that might be a difficult argument to make.
Okay, well, there's no coverage for anything we're actually sick of, which is, I'm struggling every day with my healthcare. Quick comment, because the people are coming in from upstairs, and that means we're going to be ending.
So I have practiced in Karachi, Pakistan, and I've seen so many, because of the sanitation condition and very close population living together. So I've seen so many, patients, they take the antibiotic themselves, okay? But I have seen more rheumatic fever with involving heart rather than the chorea.
Did you guys get that? Yes, and I would agree completely. The strep actually are different. If Madeline had the microphone, she'd probably speak to that point. But
I can give Madeline the microphone.
Sydenham, Korea, well, or I can just finish it up. So the rheumatic carditis is actually a different set of antibodies than the Sydenham chorea.
Oh, yeah.
And the genetic vulnerability is also slightly different. So the other piece of that was when we first started looking at Sydenham chorea, we looked at patients who had rheumatic heart disease without any Sydenham chorea and those who had Sydenham chorea plus or minus rheumatic heart disease. It was only those in Sydenham chorea that we saw the obsessions, the compulsions, and the other psychiatric symptoms. So. I know. Hopefully they take it for more than a day or 2 because the strep would come back.
Well, can I say one comment? Can I say just one thing? I have some happy news to say that right now our emergency room doctors are starting workups for PANS and PANDAS without calling us, and a lot of the pediatricians around us are doing the same.
So I don't want you to go away yet. What? Well, now go ahead. I guess so. Oh gosh.
This has never been mentioned to me before in all my, lectures that I've attended, et cetera. Is that something that you're aware of, and do you recommend prophylaxis for certain dental procedures for a PANDAS child?
So I don't know if I've definitely seen kids who have lost teeth or have dental work right? And I was speaking with a dentist recently about this, about just how, and they were saying absolutely that dental work moves some oral bacteria into the bloodstream and increases systemic inflammation in general. So I have covered kids prophylactically for antibiotics, not extended periods of time, but I think more important is probably the anti-inflammatory treatment afterwards for an extended period. But I wouldn't say it's the norm, but it routinely comes up as far as dental work and lost teeth for starting symptoms.
Yeah, really quickly, I want to say that losing teeth and remolding your bone in orthodontia are inflammatory events too. So we see kids having flares with those.
So we answer. Okay, so that is. Thank you very much for the panel time, and we're going to.